a pleasure to be invited to speak on behalf of the Society for Integrative Oncology, a society that I have been part of now for many, many years, and I encourage the attendees for this our website and learn about who we are, and very importantly attend our annual meeting that is going to be in Vancouver, Canada this October. So as the title of my talk indicates, I'm going to be really focusing on the field of mind-body medicine as it applies in oncology, with, of course, an emphasis on the research. I'll first be discussing the area of stress physiology, stress biology, in particular how it pertains to cancer, and then the second part of my talk will be focusing on managing that stress implications for cancer outcomes, and then at the end highlighting some of our clinical trials, both some that have been published and discussing some of our ongoing research and current interests. So let's start by looking at the stress response that you see pictured here. Our body's stress response is really a hardwired response that evolutionarily is something that is extremely adaptive. So when historically we were in a situation that in particular could pose harm or threat, our body mounted what is known as an acute fight-or-flight response. And this, of course, allowed us to get out of the danger that we were in into a safer neighborhood where there wasn't a predator. That is typically, historically, what was the most problematic in causing stress for individuals. And so this hardwired stress response, which would result in the release of stress hormones, an increase in heart rate and blood pressure, a increased efficacy of the body to be able to transport oxygen into the muscles, a shunting of blood from internal organs into the muscles to be able to run. There was a increase actually a decrease in platelet clotting time, meaning that your platelets are going to clot faster, and of course this could be very important if you are caught by that predator. And it even changes your vision, and you're able to see long distances slightly better than you would otherwise. And so as I've just described in terms of this fight-or-flight response, when you have a prey coming down upon you, or you're in a situation that you are hearing a rustling in the bushes that could be a predator, that this is something, of course, that's going to be very adaptive. And evolutionarily, in some sense, we were selected for, and the individuals and species that were able to live and reproduce were the ones who had a very attuned stress response, again, being able to get out of danger. Now, that hardwired stress response is identical even in situations of chronic stress, which I don't know, of course, the facts in terms of the history of the evolution of the species, as nobody really does, but it's unlikely that our ancestors experienced a lot of chronic stress. It was typically these acute stressful situations, and then you either were in serious trouble and succumbed to the threat, or you were able to get to safer territory, and then the stress would disappear until the next time it appeared. In our current environment, we tend to be experiencing a lot of chronic stress, and the physiological effect that we experience within our bodies is essentially the same. So you can see pictured here essentially two pathways, in particular the ACTH, release of ACTH, and the autonomic nervous system as well as the sympathetic nervous system with the release of, in this case it's listed as noradrenaline and adrenaline because this is published in a British publication, but what we in the U.S. would call norepinephrine and epinephrine, and being released from the adrenal glands, cortisol. So this stress response has been studied for really close to very good data, certainly in the past 50 years, if not even longer. And its application in many chronic diseases is well established, in particular in cardiovascular disease, in GI-related diseases, and when we apply it to cancer, this is where the data is a bit more challenging because it is hard to study groups of individuals who aren't experiencing chronic stress to individuals who are, and then you look at the development of cancer over time as an example, these large epidemiological studies. One of the challenges is it's hard to really assess this concept of stress because there's such heterogeneity between individuals and how they respond to stress, the different coping resources they may have, as well as the fact that there's tremendous heterogeneity of cancer. We just use this term cancer quite generally, but of course, even within the category of breast cancer, as we recognize it today as breast cancer, there are many, many different diseases. And in terms of the characteristics of the tumors, the etiological factors that were involved. So it becomes quite complicated. But what we can do is very well-controlled animal studies where we can subject groups of animals to psychological stress compared to groups of animals that aren't, and then we can do all kinds of manipulations with different cancers and different modifications of their physiology. And Anil Sood, who is a gynecological oncologist here at MD Anderson, the senior author on this landmark Nature Medicine paper, did exactly that in terms of examining, as it says, the effects of chronic stress on tumor growth in an ovarian cancer animal model. And let me orient you to these two graphs. On the right, we see the tumor weight, so the size of the tumor, and on the left we see the number of tumor nodules, so essentially the spread of disease throughout the body of these mice. And the first bar in each of the graphs represents the control animal, so they're injected with a known amount of ovarian cancer cells, and then you watch over a month period of time how much the tumor grows. The second bar in each graph represents the animals exposed to the cancer cells as well as exposed to chronic stress. And there is a tremendous growth in the size of the tumor as well as the spread of the disease throughout the body. More than 50% of the animals experiencing chronic stress had spread of disease throughout the body, whereas the control animals had it confined to the site of the injection. Why this was such a revolutionary study is represented in the last bar of each graph, which is that if you gave these animals propranolol, which is a very common beta blocker, blocking the effects of norepinephrine, this very common stress hormone that we know is released during times of chronic stress, you block the effects of norepinephrine, the effects of psychological stress on tumor growth totally disappear. It's not just that they're just diminished, but that it totally disappears. So Erica Sloan in Steve Cole's lab at UCLA, also in collaboration with Anil Sood, whose name you see second to last on this paper, used this exact same chronic stress model, restraint stress model, and switched, and as you can see, was looking at this in a metastatic breast cancer model. What's interesting from the way they set this study up is that they, as you can see, were able to image the tumors over time. throughout the 4 weeks of the experiment. And you can see an example here of one of the stressed mice that by day 24, the mouse had metastatic disease in the lungs, and by day 28 in the lungs and the lymph node. And on this graph, you can see on the bottom left here the control animals where there is no metastatic disease, absolutely none. And of course, you see the stressed animals, just tremendous amount of metastatic disease, again in the nodes, in the lungs. And interestingly, the graph on the right represents the growth of the primary tumor, where it is growing similarly in both the stressed and the non-stressed animals. So at least within this model, there was a clear impact on that stress was driving metastatic disease. And of course, we know that it's metastatic disease that is really what is taking the life of cancer patients, and typically not the primary tumor. So here we see similarly the addition of propranolol, the same kind of graph on the top left there, that the animals that had stress and no propranolol, lots of distant metastatic disease. You give those same animals propranolol, the beta blocker blocking norepinephrine, there is no metastatic disease. And in fact, they seem to have in some sense, slightly less metastatic disease with stress and propranolol than the animals who didn't even have stress. The same is true giving the animals isoproterenol. Isoproterenol is essentially a norepinephrine agonist, meaning it's going to stimulate and increase the release of norepinephrine in the body. So with these two experiments, and there's many others, we see that stress can literally get right into the tumor microenvironment and literally wreak havoc on the system and make it hospitable to cancer growth. And this is through modification of aspects of the immune system that we haven't even talked about in detail, but there's a decrease in cell-mediated immunity, which is very relevant for helping to control metastatic growth. There is actually an increase in migration and invasion specifically of cancer cells, a decrease in apoptosis, spontaneous cell death, an increase in angiogenesis and pro-angiogenic cytokines, so that the chronic stress leads to a increase in self-vascularization, that tumors release these factors so to help create its own circulation so that it can help to keep the tumors alive. So this now is extremely well documented at multiple levels, again, primarily within animal models. So what we did was study in collaboration with Anil Sood, Dr. Pisters here at MD Anderson, and Steve Cole at UCLA to look at one of the hallmark symptoms of chronic stress in cancer patients, which is depressive symptoms. This was a very homogeneous population of patients. They all had stage 4 kidney cancer, so advanced disease, all newly diagnosed, and we were particularly interested in whether depressive symptoms at the time of diagnosis would be a predictor of survival. And as you can see here, there was a hazard ratio of 1.5. The patients represented in the gray color having a depressive symptom score that was below the clinical cutoff, and the ones in red above the clinical cutoff, showing a differential effect in survival. We were also interested in cortisol rhythmicity, cortisol regulation, and similarly to norepinephrine, this is a stress hormone, but it is it has a diurnal pattern, that is high in the morning and then drops throughout the course of the day. And a blunted cortisol slope has been associated with worse survival in stage 4 breast cancer patients. And here we were able to demonstrate that a flattened slope, a blunted slope, in these patients was also associated with worse survival, even when you control for the standard prognostic indicators. You see a hazard ratio of 1.9 for the patients who have a flattened slope. What we saw further is that we looked at the blood of the patients who were the most depressed and compared them to the patients who were the least depressed and matched them on all the important factors related to their disease, their treatment, etc. And we saw an upregulation specifically of genes involved in inflammation, immune response, and negative regulation of programmed cell death. And so that means a decrease in apoptosis, which is, of course, not something that you would want to have, and a downregulation in genes that are involved in cell trafficking, adhesion, oxygen transport, and hemostasis. Doing a promoter-based bioinformatic assessment of this very complex gene array data, we saw that there was specifically an increase in activity of pro-inflammatory NF-kappa B as well as STAT1 transcription factors. Now these two components of cellular function are areas that we know are pivotal in metastatic growth and in cancer growth. And the conventional drug world is really focused in particular recently on looking at molecules that will specifically help to regulate STAT1 transcription factors and, of course, to block NF-kappa B pathways. We were able to, on a subsample of these patients, get some actual tumor tissue and look at tumor-associated macrophages. And we saw that comparing the high to the low on depression scores, that there was a higher expression of HIF-1 alpha, MMP2, MMP9, and COX-2. Again, these are pathways that we know are related to cancer growth. And so from this paper as well as others, there's been a clear link between depression and depressive symptoms and mortality, as well as now a better understanding of some of the pathways at a molecular level now that are explaining some of these associations, where there's an increase in inflammation, downregulation of aspects of cell-mediated immunity, and literally having an impact on inflammatory signaling that is part of the cancerogenic process. So is there a positive side to this? Well, luckily there is, and a recent publication from Susan Lukendorf's laboratory, who has been studying ovarian cancer patients for more than a decade now, this large cohort of ovarian cancer patients, she was able to demonstrate that there was an association between healthy social attachment and survival over time in these cancer patients. And you can see that pictured here, that the women who were classified as having high social attachment living longer than the women classified as low social attachment. And this again is at the time of their original diagnosis. Delving deeper into the actual cells, at the tumor site, at the time of their surgery, they collected norepinephrine levels right from the tumor. And you can see here that as total social support and social well-being goes up, norepinephrine levels actually go down. With, of course, the flip side of it is that the women with low social support had higher levels of norepinephrine literally at their tumor site. And as I described to you earlier, having high levels of norepinephrine is probably not something that is going to help with your outcomes. Since a lot of this research has been done, in particular looking at norepinephrine and beta blockers, a number of clinics around the country, and in fact in some other countries like Israel, they said, well, we see Dr. Sood's data looking at beta blockers, buffering stress, influencing angiogenesis, and all these other pathways. Let's look at our patient populations and collect information on the ones who are on beta blockers and compare them to matched patients who aren't on beta blockers, and then let's look at clinical outcomes. And in fact, what they found, and this has now been replicated in breast cancer, ovarian cancer, prostate cancer, most recently lung cancer, is that patients who are on beta blockers, and in particular propranolol, they lived longer and had a lower probability of recurrence of disease. Now, they weren't taking, of course, the beta blockers to treat their cancer or probably to treat a stress disorder, but they were taking the beta blocker for some cardiovascular-related risk factor like high blood pressure, etc. But what it does point to is that there are influences of sympathetic nervous system pathways that we know are intrinsically and very sensitively linked into our psychological processes and psychological well-being. Now, if we go even further into the cells, and I'm not going to go into too much detail on this factor, we know from some very elegant research that chronic stress can literally shorten your telomeres. And you can see telomeres pictured here on the end of the chromosomal strands. And telomere shortening is highly correlated with aging and the aging process, and this is perhaps one of the reasons why one of the most important risk factors for cancer is advancing age, is that the telomeres shorten, and as they shorten and the cells replicate and divide, you get what's called chromosomal instability, and as the chromosomes divide and you have chromosomal instability, this can lead to mutations. Now, hopefully apoptosis can kick in, or aspects of the immune system can kick in to regulate that inappropriate growth. But under periods of chronic stress where you have, as I mentioned, modification in all these systems, and in particular accelerated telomere shortening, this can be quite problematic. And this was first demonstrated in this paper in PNAS by Elise Eppel and her very close colleague Elizabeth Blackburn. And Elizabeth Blackburn, of course, is known for her work in telomere research as well as telomerase, for which she won the Nobel Prize 3 or 4 years ago in medicine, the Nobel Prize in medicine. This has been replicated now in a number of different studies showing that chronic stress can literally accelerate telomere shortening and is directly related to the aging process. So to kind of close out this portion of the talk, we know, of course, that the diagnosis and treatment of cancer in and of itself can be extremely stressful and has all these profound physiological changes, literally impacting every single cell in our body. Stress also, of course, will negatively impact patients' quality of life, and together this can, in theory, have a effect on treatment response, disease progression, and overall survival. And so it is now time to really engage patients in trying to do everything they can to manage their stress. And this, of course, can be many different kinds of intervention programs, conventional things like psychotherapy and support groups, etc., and then other programs that would fall more into this area of mind-body practices, complementary medicine, things that you see listed up here, such as yoga, tai chi, qigong, expressive writing, meditation, neurofeedback, etc. And this can, in theory, have an impact on the stress that the patients are experiencing, as well as on their quality of life, and importantly trying to modulate the physiological and biological measures. Well, Mike and Tony, who published this paper just at the end of last year, has been studying psychosocial processes in breast cancer patients for a number of years, and they found that patients who were randomized to a cognitive behavioral stress management group had improvements in aspects of quality of life over time, better cortisol regulation, aspects of the immune system were impacted. But in this very important study that you see here, they actually looked at similar analysis of the genes and doing gene array work. And they found actually in the stress management group a downregulation of pro-inflammatory and metastases-related genes and an upregulation in type 1 interferon response genes. And type 1 interferon is useful for driving cell-mediated immunity and maintaining higher function in cell-mediated immunity. And you can see here that they actually showed a decrease in the activity of NF-kappa B related transcription factors, where, as I mentioned earlier, in our depression study, we saw an increase in NF-kappa B. So in the exact direction that you would hypothesize, depression leading to an increase in NF-kappa B, and in this randomized clinical trial, where we're seeing actually a decrease in NF-kappa B for the ones who were in the cognitive behavioral stress management group. Shifting and describing a little bit of some of the work that we've been doing in this area over the past number of years, one of the earlier studies we published was looking at a form of pre-surgical stress management, and in some sense a very conventional approach based in the area of cognitive behavioral therapy, where in this randomized trial, we taught patients a very simple form of guided imagery, relaxation, a breathing technique, a procedural imagery of the day of surgery, and importantly had a usual care control group, but also an attention control group. So the patients in the attention control group met with the clinical psychologist for the same amount of time as in the stress management group, but they didn't learn any specific skills, but they were able to do reflective listening, sharing their story, etc. And we found in the short run there was an improvement of mood in the stress management group, in particular compared to the usual care control group, with the attention group falling in the middle, but not different than either group. And most importantly, a long-term benefits in reference to patients' physical functioning and quality of life even a year later if they were in the stress management group. We also analyzed the immune function, and in particular natural killer cell function and some inflammatory cytokines, and found that there was actually a decrease in function from pre-surgery to 48 hours later if they were in either control group, and an increase in function if they were in the stress management group. So showing both a impact on self-report, mood, as well as physical functioning, as well as a more objective outcome, specifically in this case, immune function. I thought I would share with you this very important work from Elvira Lang. Again, somewhat of a conventional approach to a mind-body practice, what she calls self-hypnosis or medical hypnosis, really a form of guided imagery, but conducted in a way that is related to aspects of hypnosis that are embedded in the procedure. She's been doing this now for a number of years with a number of different invasive medical procedures where the patients are actually, of course, awake during the procedures, maybe on light anesthesia, but they're able to communicate. And in particular, in many of these procedures, there's a tremendous amount of anxiety. And so you can see here, this was a three-arm trial where she's comparing standard care to an attention control group versus the hypnosis group. And you can see over time, both pain and anxiety over the course of the procedure is reduced. And that actually increases in particular in the standard care group. And what's also important to note is that along the timeline across the bottom in terms of procedure duration, all of a sudden it's over in the hypnosis group, which is showing that on average the procedures were done faster. Specifically in reference to breast cancer, she did this in patients who were undergoing large core biopsy, for diagnostic procedure. And there isn't that much pain because there's local anesthesia, but you can see that by the end of the procedure, anxiety is down to 0 if they had the hypnosis, and in both an attention control empathy group as well as standard care, it's remained high, or in fact higher than it was when they entered the study. This has been shown now not only to be effective in terms of managing the symptoms of pain and anxiety and improving satisfaction scores of patients undergoing these invasive medical procedures, but now also been shown to be cost effective, taking into account the fact that there is an individual whose salary was paid for, who was sitting at the head of the patient, guiding them through this procedure. So because the procedure was done faster, the hospital could do more procedures in a day, there was less anesthesia used, there's increased satisfaction. I mean, everything in terms of assessment of the concept of the value proposition under our current healthcare reform focus would suggest that this type of intervention really should be the standard of care. Now, if you're able to teach somebody on the healthcare team who's already in the room or working with the patients for the ongoing procedure, this very simple technique, then the cost savings would be even more profound. So let's shift a little bit, which is a really important study that looked at meditation. And previous research has shown that meditation can actually have an impact on our electrical activity of the brain, that after learning a mindfulness-based stress reduction or other forms of meditation, we see that there's a change in the function of the brain, and the change in that function of the brain has been related to aspects of downstream, so to speak, physiology and aspects of immune system, etc. But this landmark study was very important because it went really beyond that and looked at neuroanatomy, the brain gray matter density. And as you can see here, there was actually an increase in left hippocampal size for the patients who were in this brief, relatively speaking, 8-week mindfulness-based stress reduction program. These were all meditation-naive individuals. So this suggests that in a relatively brief period of time, not only do we see changes in the electrical activity of the brain, but you literally see changes in the anatomy of the brain, with an increase in this case in the hippocampus, which is related to memory and memory consolidation, and there was a decrease in the amygdala, the centers of the brain that are involved in processing negative emotions. So there's a huge interest in what we call the mind-body practices. And of course, one of the most well-known mind-body practices from the East is yoga, which of course is a movement-based meditation, if we are to think of it in that way, which is a combination of regulating the breath, regulating the body, with the ultimate goal of finding and seeking calm in one's life. We've been doing research now with Patanjali-based yoga with our colleagues from the Vivekananda Yoga Research Institute in Bangalore, India. and specifically integrating yoga into the radiation treatment plan for women with breast cancer. And in this study that I'll describe to you, we had the women participating in either a yoga group or a stretching control group 3 times a week for throughout the 6 weeks of radiation treatment. And we collected measures at baseline, then at the during the last week of XRT, and then 1 month, 3 months, and 6 months later. And you can see here the basic consort flow diagram where we're able to randomize over 150 patients into the 3 groups and had pretty good follow-up with more than 40 patients remaining in the study even 6 months later. The main finding that replicates a previous 2-arm study that we had was improvement in physical functioning as assessed by the SF-36. What's pictured here is actual change scores, so change from baseline, which is just at the start of radiation treatment, and then end of treatment 1 month, 3 months, and 6 months. And you can see there's actually a slight improvement by the end of radiation treatment if they were in either one of the yoga groups, but not significantly different than the main control group. But then at 1 month, 3 months, and 6 months, we see this increase in function if they were in the yoga group relative to both of the other groups, and the stretching group in some sense falling in the middle here, but it was only different than the control group at this 3-month time point. A measure of more general health, again from the SF-36, favoring the yoga group over both the other groups at 1 and 3 months. And this important measure of benefit finding, ability to find meaning in the illness experience, improved at 3 months and 6 months from baseline scores, where we still see this increase over time, but a decrease over time if they were in either one of the control groups. For this study, we're interested in also measuring the stress hormone cortisol and cortisol rhythmicity. So you can see pictured here an example of literally what cortisol rhythmicity looks like. It's high in the morning, and then it drops throughout the course of the day, and typically at its lowest level 12 hours after awakening and at around bedtime. What we see, you see pictured here, all 3 groups overlapping each other. By the end of treatment, there's actually a blunting of the slope, and there's a blunting of the slope in all the groups, but much less so if they were in the yoga group, and the yoga group having a significantly steeper slope than the other 2 groups. And of course, as I mentioned earlier when we were talking about the depressive symptom data, a blunted slope has been related to survival, both in our data with renal cell carcinoma and David Spiegel's work with stage 4 breast cancer patients. In Shanghai at the Fudan University Shanghai Cancer Hospital, we were interested in following a very similar model of integrating a mind-body practice into the radiation treatment plan for breast cancer patients, but in this case it was a Qigong practice. This was a practice that comes from the tradition of Guoling Qigong. Guoling was a breast cancer survivor who developed, in working with the ancient practice of Qigong, some of the movements that she thought would be particularly useful for breast cancer survivors. And in this case, we had them participating in the Qigong intervention actually 5 days a week throughout the 6 weeks of radiation. And you can see that of the patients randomized to the Qigong group, we actually had perfect follow-up across the course, in this case, of 3 months of follow-up. And in the control group, only 1 person dropped out between 1 month and 3 months, and that was actually because they died. So really a perfect record in terms of keeping patients in the trial. What was a little more surprising is that the effects were somewhat modest compared to the intensity of attendance that we had for this particular mind-body practice. But you do see here the main effect that we saw across the course of the study, which was this decrease over time in depressive symptoms and a stable, relatively high level in the control group. So based on some other research showing that it's really patients who are more psychologically distressed at the beginning of these psychosocial studies that would benefit, we split the patients in terms of their scores on the CESD at baseline and looked at the ones who were high versus the ones that were low, and then looking at them by the group assignment of treatment or control. And you can see that picture here. So the bottom two lines represent people who were low in depression scores at baseline. And you can see there the lines really overlapping each other and being low over time. So if you don't have high depression scores coming into the study, whether you're in the Qigong group or not, your depression scores are going to stay low, and that's not too surprising. But what we see in the other components of this graph are the patients who have high depression scores coming into the study. And if they're in the Qigong group, they are reduced dramatically over time, and they stay very high and, in fact, increase if they're in the control group. This is similar outcomes that we see for FACT, which is a cancer-specific quality of life scale, where we see it's reduced at 1 month post-radiation treatment if they're high in distress and in the control group, and the other groups remain similar. And for cancer-related distress, the impact of event scale that we see is going down over time if they're high in distress at baseline, and yet it remains high and is increased if they are in the control group. So where this research is really going is trying to better understand, both from, as you see pictured here, adept experts in mind-body practices to novices, trying to better understand what's literally going on in the brain, not to ignore the first-person narrative of the individuals, but to get some more subjective measures of what's going on in the cerebral level. And so in collaboration with the Ligmincha Institute here in Houston, we were particularly interested in looking at the effects of a kind of meditation coming from the Tibetan tradition, a Tibetan sound meditation, to specifically treat chemo brain. There's been, as I mentioned, research that has examined the relationship between meditation and different brain structures, and the components of the brain that we know are negatively impacted by chemotherapy, and the cognitive processes that are negatively impacted by chemotherapy. We've seen from meditation studies with healthy individuals that those same brain structures can be positively impacted, and that we see an increase in some aspects of cognitive functioning. So we embarked on the study specifically using these 3 sound syllables from the Tibetan bone tradition that you see pictured here, the sound of Ah, Om, and Hung. And when the individuals are learning these 3 syllables, they're of course focusing on their breath as a very important component of this practice, but they also are engaging in a different part of their body when they're emitting the sounds. And when they're emitting each sound, there is a cognitive task that they're also engaged in terms of overcoming different obstacles and work that they're doing at an emotional and spiritual level. So it's in some sense it's a focused form of meditation that we believe would have an impact on cognitive centers of the brain. So what we did was a very small N of 40 randomized trial, half in the meditation group and then half in a control group. And we can see here a change at the 1-month time point in specifically measures of objective cognitive functioning. So these were cognitive tasks that they did on a computer, and we see an improvement in working memory if they were in the Tibetan sound meditation group compared to the weightless group, not reaching statistical significance, but this again is the pilot study and going, of course, in the expected direction. And similarly for a measure of speed and executive functioning, improving more so in the meditation group versus the weightless. Looking at the more subjective measures, the self-report measures we see on the first two represent cognitive functioning measures, and then significant improvement in measures of mental health, the intrusive unbidden thoughts, intrusive thought scales lower, mental health improving, depression scores going down, and the last one being a measure of spirituality and spiritual well-being improved if they were in the Tibetan sound meditation group compared to the weightless group. So we have a lot of ongoing research in this area. The follow-up, the second bullet there, the follow-up study to the Patanjali-based yoga study that I mentioned that we're doing with the Vivekananda group, we're now doing a large phase 3 trial where we're actually comparing the yoga group to a more intensive, actually, control group where they're not only going to be learning some stretching exercises, but also some very simple relaxation skills, so that if we find that, in fact, there are differences between those two groups compared to a usual care control group, and differences between the two forms of relaxation, as we're calling them, then we'll really know that there's something unique about yoga that goes above and beyond just relaxation and simple moving of the body, which yoga practitioners, of course, hypothesize that it is more than just simple movement and relaxation. We're doing a follow-up of the Tibetan sound meditation study as well, a larger sample size where we're conducting the research both here as well as Albert Einstein Institute in Sao Paulo, Brazil, where we're going to be able to do much more in-depth examination of the brain and brain function by incorporating both EEG as well as fMRI research. And the neurofeedback in this Loretta neurofeedback is a very exciting area of research that a postdoc in my group, Sarah Prinsley, is very focused on, which is being able to assess the way the brain is functioning from an electrical perspective by doing EEGs. And from that EEG, seeing compared to a database of quote-unquote normal EEG patterns, where there is an aberration, for example, in people who are experiencing peripheral neuropathy. And then through neurofeedback, which is a computer-brain interface, being able to, similar to biofeedback, provide signals to the brain on how to modify that electrical activity with the goal of changing the way that it is processing the symptoms that it's experiencing from the periphery, with the goal, of course, of decreasing pain. This has been done with some chronic pain populations, both in a real-time fMRI setting as well as with EEG neurofeedback in, again, general pain populations, but has never been done in an oncology population. And that's what we're doing both with a peripheral neuropathy study as well as a study of neurofeedback during head and neck radiation to try and decrease the onset of pain that is ultimately inevitable due to the radiation to the head and neck. And the last thing to just note that we have ongoing is to try and look at further the work that Elvira Lang was doing in looking at a guided meditation during breast biopsy. This is work that Chelsea Giltz, a student of mine, her dissertation is focusing on that during breast biopsy. And then trying to bring this really into the real world of trying to train people on the team to do this, so that hospitals can't say, well, we don't want to have that added expense of a hypnotherapist and somebody who's specialized on the team, to be able to train technicians to be able to do this. And bone marrow aspiration is something that happens on average 70 times a day at MD Anderson, an extremely stressful and for many people painful procedure. And wouldn't it be wonderful if there was somebody already on the team who we could train to do this kind of thing and document that not only do patients have decreased pain, anxiety, but it improves satisfaction, procedure can be done faster, etc. So there's a lot of people involved in the work that I presented to you today that I show pictured here, both from our colleagues in India, as well as Tenzing Wangyal Rinpoche, Alejandro from the Tibetan tradition, lots of individuals from the medical side of the street, our breast oncologists, and others who are part of the team. What's important to note also is that this area of mind-body research is very well recognized and supported by the National Cancer Institute, supporting this type of clinical trial. They're particularly interested in biobehavioral processes, and there is a biobehavioral research branch within the NCI that is very interested in trying to understand the relationship between psychological processes, biological processes, and in particular disease outcomes. So we have come to the end, and I thank everyone for attending.